You are welcome to presentation which was made to the conference organized on health matters. And this is dementia as part of that conference held in Ealing Community Church on the 17th of May, 2025. So welcome to this short presentation.
Yeah. All right. Thank you very much. So, good morning. I was going to say good morning, church, but we are in the church, in the building. All right. Thank you very much, Jane, for setting the pace. I don't know whether I wasn't sure whether the introduction will be done by someone or I need to introduce myself. So, my name is Prosper Doe, and I've just got a friend here, George, isn't it? Yeah, I always say that I can't help it but to prosper. And George has formed a lot of adjectives and superlatives with my name, Prosper. Thank you, George. As introduction, go to the point. It's on dementia. I always, as a lecturer, students, I need to use this. I should be in control. Now, let's see. Let me try it. Yes. What would you like to know about dementia? I'm not expecting an answer because the time will not allow us, but just reflect on it. It's such a broad topic that usually it takes an hour or so dealing with medical students. So not to say that you don't know dementia. Some of you have heard, some of you have experienced living with people living with dementia, but I'll just whistle stop journey with you, even on this topic. And I've worked with the NHS since records began. I'm joking. For, well, about 20 odd years. And I'm currently psychiatrist, as you can see the topic. Also, well, I'm working now. I've worked in various departments in psychiatry, but now decided to settle on the older adults, not because I'm that old, though I have some gray hairs. I work in the community, and we say that I've had some award in my bio is there. I've had some experience in public health, being a district director of public health abroad, and also been a head lecturer in dermatology, skin. You wonder why I'm doing psychiatry, but that's a long story. And I told George, he asked me whether I like my job. I say, yes, I enjoy it. I enjoy doing my job, and I'm being paid for what I enjoy. Isn't that nice? So that reduces the stress, isn't it? We've talked about stress. Now let's go. Introduction. This is the introduction. In the UK, there's an increase in the old who are more than 80 years compared to the young old, that's 65 to 80. And the prevalence of dementia is doubles every 5.1 years after the age of 60. Now, the absolute number of dementia cases is going to increase, and we can see that even in our clinic. We have a backlog. After we have even gone to see our patient, the admin we dictate and we type the letters, and there's a backlog. They are working, they are very good. We don't have typists anymore. We have administrators. We have a backlog about 1 month after I've seen the patient for them to just catch up. And that's how much this condition is. And it's one of the biggest challenges of our time. And we'll come to that. And over 850,000 people in the UK are living with the condition. This was as far back as 2020. So you can increase that figure. All right? And more than half of us, we know someone affected by it. Not to ask for those. How many, show by hands, who knows someone who is affected by dementia? Or if you're affected by, you know someone, you are someone who knows someone who is affected, and you are the one affected by the person who has dementia, I can raise your hand. I can't see you all, but I see quite a few hands are up. Okay, hands up. Thank you. And there are no effective treatments to solve or prevent the disease, like Alzheimer's that causes it. Yet. I said yet because I'm optimistic. All right? I want to give you hope. There's a lot of research going on. So we never say that we have finished search. That's why the word research is there. Maybe the one to discover the cure is the baby that was born yesterday. All right? And I want to give us that hope that the word of God says in 3 John 2 that it is my words, prayer for you, that you will be in good health, even as your soul prospers. And that includes dementia and every condition. All right? And John 10:10 also says, the B part, Jesus says he has come to give us life and some abundance in all its fullness, isn't it? Full abundance. All right? So that's God's plan for you. So don't think of, I want to kill myself. People want to kill themselves. No, we are not in medicine. I'm not going into the suicide debate. But the Bible doesn't give up on you. The Bible gives us hope. Jesus gives us hope. So even as we go along in dementia, living with people living with dementia, don't give up, because there's I'll say at the end of my slide more. Now, the mortality, we know it's the leading cause of mortality. Mortality is death. And it's even, people are dying of dementia, and it's even overtook heart disease in 2017. So now, I don't know the legend, but this is how important it is. It's a silent killer. All right? And the number 850 living with dementia, I mentioned it. And Alzheimer's disease is the most common cause, affecting 6 in every 10 people with dementia. I'll show you. I usually illustrate it this way. I'll ask people if people ask me, is dementia the same as Alzheimer's? I don't know your answer. Is it the same? How many feel it's the same? Show by hands. Yes. Okay. Hands down. How many people feel Alzheimer's is not the same as dementia? Show by hands. Okay. There's no middle ground. How many abstain from abstaining? Okay. Cast your vote. All right. Your vote is your power. All right. There are no abstentions. We'll go on. All right. Yeah, it's just to make sure nobody is asleep. All right. Now, I've summarized everything now with this. Remember, if you forget everything, I brought it in the middle, not at the end. Remember this. We call it a Venn diagram, and students understand it, and everyone understands it. If you don't understand it, see me later on. Maybe there's something happening. All right? You need to understand this. It's very simplified. All right? Just focus on the middle bit. You can see the lighter bit intersection. Yes. Dementia, basically, there's a global intellectual deterioration. These are big words to do with your memory and the rest. All right? Which is global. I'll come to it. Now, it's not just memory, because there are, how many of you, I won't ask people to raise their hands, you had intention of going to the kitchen, to the fridge, to pick something. And when you got there, you said, why am I here? And then you take some steps back, go into and then the bedroom, then you remember that it's milk. Then you go for it. And another time, it's something else. You're shopping. You arrive in the posh one, like Harold. I wouldn't say the other one. And you wanted to buy something. And then you got this, why am I in this shop? And then as you go to the car park, you say, oh, yes, it's this one. So next time you decide not to embarrass yourself, you make a shopping list, isn't it? So that now is that dementia? I leave your answer for you. Looking at this, there must be a functional impairment, as James said also, like stress, depression. There needs to be the functional impairment is not to do with physical activity. It's to do with mental skills, function that you have lost as a result of your memory. So you are not able to function as before. If you forget the milk and you later on went for it, it's not dementia because you are still be able to make the tea. All right? So don't feel so bad. You don't have dementia. All right? If there's a functional impairment that is continually, you've lost that function. It could be any skill that you were able to perform before, which is second nature, and that memory has affected. You are in a familiar place. Now you've lost, you are wandering. You go to the shopping, you can't find your way back home. And you are moving in the opposite direction. Instead of going east, you've gone west. And then you are found roaming around. And those are functional impairments, all right? That is where dementia sets in. Now, so dementia, for those who are, who want the more, not just the little snack thing, that is the MITS, all right? That's an international classification of disease. Sometimes not sometimes, my mentor will say, what you define, you're able to modify. What you don't define, you cannot, you are overwhelmed by it. So in order not to be overwhelmed, that's why I put this slide on. It's a chronic progressive condition with multiple, different functions of the brain are affected, all right? Which includes the memory. So it's not just memory, the thinking, slowness of the thinking, registering thoughts, and orientation. That's I mentioned about orientation to place. People getting lost in familiar places. And then also calculation, learning capacity, usually the short-term memory. The long-term memory about childhood, the person can recount in details their childhood friend, where they were playing. Those details are just there, the long-term, but it's a short-term. You mention something and then in 5 minutes, the person, you need to repeat that information, repeatedly asking, oh, but why? Our first speaker mentioned about children asking why, isn't it? The person keeps asking, oh, why? You've explained it 5 minutes ago. And then say why, and you realize that something is not right. And then there's no consciousness loss. That is very important. The person doesn't lose consciousness in dementia. Some of the time, we have people, and Jane will bear me out, we have people who, one, because of their age, and then because they are presenting as confused, which is changing, and they said they ring and they said, oh, we've got this patient, maybe we think he's got dementia, and they ring our service. We said, well, has the GP checked so and so, which I'll come to, and they said no, and we asked that GP kindly go and check. Jide is with us. Dr. Shovitum will give us something on the mens, and then they check, and then what do they find? They find it's an infection, water infection, we call it, but UTI. And when it's treated, the person regains their what do you call it? They are able to function well. So there's no loss of consciousness with dementia, and it's accompanied occasionally with deterioration of emotional control, social behavior, or motivation. These are big. I don't have time to. We don't have the time to unpack all of it, but just trust me for it. And that's the definition in the ICD-10. There's now ICD-11, but it's not. That's for academic. All right. And there are these features which happen. So it's not just the mind. What we call BPSD, that's behavior and psychological symptoms of dementia. These doctors are here again. All right? And this includes some of these behavior: agitation, aggression, whether verbal or physical, wandering, pace, restlessness, sleeplessness, sexual disinhibition. All these affect social, go against social norms. All right? Not all, but I mean, the last one, for instance, it's not all this will be in one person, but if you, their personality changes, there are new personality features. Usually, people lose that personality by the last thing, or it becomes more exaggerated. If they used to be controlling, they become even more controlling, or they go to the other extreme of, leaving every decision for their partner if they are married, or the other people to make decisions. Depressive symptoms, which is greater in the type of dementia we call vascular dementia, but I will not go into those details for us because of time. There may also be some features like hallucination. Example, people hearing voices, all right? In other mental health illnesses, you may have it, or seeing things which are not there. And we have a way of going through this to find out other causes. There are so many. All right, they may be suspicious because they have forgotten where they've placed things, so they'll be accusing people of stealing their money. Have you come across this before? Because they forgot where they place their keys. They say, "Where have you taken my key? Somebody is stealing my keys. Where's the front door key? I left it." No, then later on it's found that they misplaced it. All right, misidentification, not identify familiar faces, even family members. They don't identify them. They see them as strangers, and that brings a lot of problem in the family. All right. Okay. It's not. I'm pressing. There's no movement. Okay. Now these are some of the causes of dementia. You know that it's not just. So this one, to unpack all this will take a whole lecture period. But I just put it there that we know that it's not just one. And I usually illustrate it by saying that when you go to a shopping center, let's call the shopping center, which is your favorite shop? Pardon? Oh, Westfield, you are posh. Okay. All right. Or Little. All right. We go to the extremes. Okay. When I found you in Little, I'll not tell you off. But anyway, we go to, you have, let's call it dementia. When you enter, there are various aisles, isn't it? The aisles, each one has some for clothing, some for food, some for this, some for that. And you find the most, what do you call it? Popular aisle in that shop called dementia is Alzheimer's. All right? So people hear a lot about Alzheimer's, and sometimes equate it to be dementia because the most common, but the other causes also, as you can see on there. Alzheimer's is the top, isn't it? Primary degenerative condition, but the other causes like vascular, HIV infections, HIV, just an example, and it goes for maybe some cancers. They can cause dementia, traumatic, but I want us to settle down on the metabolic, or what we call hypothyroidism and deficiency, B12 and folate. These are reversible. And this is why GPs usually, before they refer, they do this B12 and folate. If there's deficiency and it's corrected, the person regains their mind, what do you call it, function. So it is not all people presenting with dementia that all is not lost. Some are reversible if the cause is found. Right? I want to leave you with that message that all is not lost. And then psychiatric condition that can present like dementia, which is the last that, like depression, the concentration is lost and the rest. And so if you don't concentrate because of depression, you cannot take in or listen to people, isn't it? So what you haven't listened to, you haven't registered. And what you haven't registered, you cannot recall. So because you can't recall, your friends will say, "Oh, there must be something wrong." And because of your age, they will think that, "Oh, yes." But the person is maybe bereaved. There's bereavement. And is going through a period of stress, as was mentioned. It's nothing to do with. If an older person cannot remember, don't classify it as dementia, because that is where the stigma comes in also. All right. Okay. So Alzheimer's disease, I'll not go into all this. all these there's various types which are shown on that. Now, managing, most people say they will want to know the prognosis. How long are they going to live for this? But I'll just leave that because these are personal questions and also planning. We have what you call, one thing I'll mention here is what we call lasting power of attorney. It's not for old people, it's for young people like you and me. All right? It's once you have the ability to choose somebody who will make decisions for you. All right? Solicitors can help you with that. We call it lasting power of attorney. We used to be enduring power for your health and your finances and welfare. You have the choice now to choose somebody to make that decision. Do it before you lose that capacity. So that when you lose capacity, then, or if, I should put it if, because we have people who are 90 years old plus, they don't have dementia. It's not everybody who gets it anyway. It's not infection, you are going to get it, no. But we need to know about it. But you need to have lasting power of attorney. I've done mine. It's not a will, you know. So you choose people, you appoint them, and they will make this. They'll make decision in your best interest only when you lose capacity. So we have that the planning aspect, then the treatment, their treatment available, and their services available also to support people living with dementia and their families. So you don't put the journey on your own. And there are safety issues, including driving. You need to inform the DPLA. They will not take the car away from you, but they'll just show you how safe you can do their own tests. All right? What we currently offer, that's what I have there. The list is not is endless. Alzheimer's Society advises. We have various information that we can get from the Alzheimer's Society, and we have the dementia. What do you call it? Concern, which I gave the leaflet. I don't know if it's on the. There are various activities that one can, and we have various multidisciplinary team. And I want to leave you with this. The approach is called, I didn't do the Venn diagram, 3 things, biopsychosocial. What did I say? Thank you. Clap for yourself. You are good students. So one, bio means biological, the approach, the medical approach. All right? Medication and the rest. I'm not going to go into all that because none of you will need that by God's grace, according to John 10:10, isn't it? That's medication. If it's folate, there's replacement. So that's medical. It's important. St. Luke was a physician. He was one of the apostles, one of the disciples of who? Jesus Christ. He was a physician. So don't look down on people who are in medicine, say they are not believers. I am in medicine, I'm a believer, and I believe that being a Christian is my vocation, and being a doctor is my profession. I'll retire from being a doctor, my profession, but I'll never retire from my vocation as a Christian. All right, so that's biological. Psychological. Psychological is important. Therapy is also available for the family and also for the one living with dementia. The psychologists are there to help. And then the social work service and housing and all that is all there. So there's help available. So don't give up. All right? Don't give up. That's what I think I'm getting to the yes. Those I'll skip the medication. I promise you, and I'll stick to my promise. So that's well, the assessment we go through. You are not going to do any risk assessment. Thank you very much for your time. All right.
So we can go up to Pakistan. I can be able to as well. Thank you. And next on our panel we have the long-term accommodation. So we have Siobhan, Tettey, and so we can join you on the stage. I think